So Jeff, yeah, well, and I think what we need to just, we're going to do everybody at once. Is that the idea? Yeah. All right, so we're going to now reconvene, and I'm going to turn it over to Jeff Botkin. But just logistics, we're going to do all the speakers now in a row and a discussion at the end.
All right, we've got 4 more speakers this morning. This next section we've titled Designing an Ethically Acceptable Investigation of MRT in the United States, and then we'll move on with Rebecca Dresser and Skip Nelson, then we'll move on to toleration of uncertainty for new reproductive technologies such as MRT. So our first speaker is Rebecca Dresser, who's the Daniel Noyes Kirby Professor of Law and Professor of Ethics and Medicine at Washington University in St. Louis. So, Rebecca, thanks so much.
Thank you. Thank you for inviting me to this very fascinating meeting. So, I don't know if you remember, in the late 1990s, there was a flurry of excitement about doing germline interventions. They had a big meeting about it in California, and the AAAS did a report related to it. And there they were talking about gene transfer as an efficient, in embryos or gametes, as an efficient way to do really somatic cell. So this would be a way you could get the change into all the cells of the child. And so germline effects were considered kind of a side effect of this. So Jeff and I were on an ELSI project looking at the human subject issues that would be raised by testing this. And so that's where my remarks come from. You also might want to look at, there was a RAC report on in utero genetic modification in 2003, where they talked a lot about what would a clinical study, what questions would need to be addressed there. So obviously here, it's similar to that earlier proposal where, you know, you want to help the later-born child, but then you have this issue of potential effects in descendants, and the monitoring, and then once you're looking at this through an ethical and regulatory human subject framework, you have a phase 1 first-in-human study involving fetuses and children and uncertain direct benefit. And so one issue, I think, is this a potential direct benefit study? Another thing that hasn't come up is, what if there are arguments about the embryos that have been where there's been an intervention? How do you handle that, embryo disposition and control? And I'll come back to that. So these are complicating features, and I think that there are some gaps in our regulatory oversight system, such as there isn't in the Appendix M for gene transfer. There's nothing about, say, what do you do about disputes over embryos? There's obviously nothing about follow-up. It's usually recommended now 15 years for somatic cell gene transfer, but when you're doing this in children and they're growing up, there's really nothing there, and the FDA doesn't have anything either, so there are some gaps. So if we look at the common rule on human subjects, it has these 2 provisions. So how would we apply them here? Obviously, we've been talking about this a lot. Preclinical alternatives, appropriate study population, and monitoring. So I'm not going to talk much about 1 and 2. So I think the selection of the preclinical population is important. So I guess I'm looking at this as maybe like a first-in-human cancer chemotherapy trial or artificial heart or something where it's high uncertainty, It may not be very risky, but we just don't know. So what would be the appropriate population here? I think we heard yesterday some discussion of, say, a woman in a family where there already had been some miscarriages and affected children, so high risk of passing on the problems to her child. The relative risk there would be more favorable in terms of ethics because obviously if you're doing like this to somebody, a future child who would be have a higher probability of being born healthy or mildly affected, the risks of the research would be relatively higher. If you're doing it with a future child who would be more likely to be seriously affected by mitochondrial disease, then the relative risk would be lower. So the second population, I think, would be the more defensible to do the first-in-human studies. So that's something to think about. I guess from my reading, I understand that it can be hard to predict what the odds are that a particular embryo will develop into an affected child. So I don't know, maybe I'm wrong about that, but that might be an issue. As far as monitoring, we've been talking about that a lot. And I do think, some of the discussion about monitoring has been more as if it's in the context of therapy. So we wouldn't want to do follow-up blood tests because that wouldn't be in the best interest of the child. But when we're doing a first-in-human trial, the justification is advancing knowledge. And if the follow-up is needed to get the data to figure out how good this is, then I think there's a stronger justification for doing it. And this whole idea of how long does the study have to go on is another one. And I think, we've been talking this morning about what are the specific tests that ought to be done in follow-up. From my perspective, I think ideally you would be covering all this in the initial consent discussion, counseling discussion, because you'd like to get at least initial buy-in to the later commitments. Now, whether they would stay committed is another problem, but I think the more they're prepared for what they're getting into, the more likely they are to follow up as you would like them to. And then if you're thinking about consent and counseling, we've got a series of participants. So you would initially have the prospective parents, and you would want to talk with them about, all the relevant information. They ought to have a reasonable understanding that of the data that will exist at the point at which they're invited to be in this trial. They should understand that preclinical data can't fully predict what will happen to their child. And even if it's, say, the fourth case, that what happened in the first three cases might not determine what happens to your child. They should understand that the intervention might produce damage or be ineffective. And they should be prepared for the possibility of embryo discard if an embryo looks like it might not, be a healthy child. And then the prenatal diagnosis issues. And this is probably the lawyer in me, but I was thinking, what if after the MRT intervention occurs in the embryo and the researchers say, well, we don't like the looks of that one. We don't think we ought to implant that one. And say there aren't that many options for the parents, and they don't have that many other embryos. And they say, but we want you to put it in. At this point, you might say, well, they could have been reproducing naturally with their high risk. So I guess we have to do what they want. On the other hand, I think once the researchers are involved in this, there is a sense of responsibility that isn't there when this is occurring naturally. And so investigators might feel strongly that this would be the wrong thing to do ethically. And so I think one thing to think about is, should there be limits on the parents' ability to control the modified embryos in this situation? And this is different from prenatal, where you have a woman's body involved. This is where they're outside in the dish. And, you know, in terms of the other situations we've been involved in with law, I don't think it's totally clarified how that would be resolved. So then, once the children were born, obviously there would be these issues of trying to get the parents to continue bringing in the child for monitoring and evaluating the health of the child. And then once the child is old enough to have some understanding, we talk about 7 in most human research, you ought to start talking with the child about what's going on and get assent, which is the child's agreement, to continue with this. And so then once they become adults, then you have to get their informed consent to continue on. And then if the female subjects had children, then you'd start all over again. So I think these are all things to think about. If you really are doing this as research, again, if you need the data to make a judgment about safety and effectiveness, then I think you need to address this question of whether enough people would enroll and stay in the study long enough to get the data that you need. So that is all I'm going to say, and I'll sit down. Thank you.
Thank you, Rebecca.